Good afternoon, and thank you for the invitation to present at this conference. I'm going to present today the results from the UK preschool autism communication trial, and start off by just acknowledging the large team of colleagues who I'm presenting on behalf of with the study from the Universities of Manchester and Newcastle and 3 sites in London, UK. We also have need to acknowledge a large team who also took place in this large trial. So the purpose of this study was to undertake a rigorous test of the kind of social communication intervention that you heard about from Sally Rogers earlier on, testing this notion of a transactional model of communication difficulty between the autistic child and their parent, the idea that the communication problem in the autistic child may have interactional consequences in terms of parental behavior that they then may lead to the child having reduced opportunities for social learning and amplifying the adverse developmental trajectory. This is a complex area, and we wanted to make a rigorous test of this hypothesis. And let me just present to you exactly what we were testing in the trial. So firstly, we wanted to test whether our intervention that I'm going to describe a little later, which is a parent-mediated intervention, it's video-aided, which addresses an enhancing of parental responsiveness to their child's communication, that this intervention would indeed enhance parental behavior in that way. We then hypothesized that enhancing in parental behavior would have a result on the child's communication initiations. In other words, hypothetically reverse the adverse interactional consequences of the autistic development. We then further hypothesized that by doing that, we would reduce the communication abnormalities in the autistic child going forward, and that these improvements would then generalize into other kinds of autism symptoms in the social and communication domain. We weren't thinking that we would affect repetitive and stereotype behaviors. So as I said, the rationale for this very much lies in this model of communicative development that's been rehearsed by Sally. And also in our pilot study, which essentially used the same design and the same intervention, but on a much smaller sample, which had shown very positive effects of the intervention on outcome ADOS scores for the children, with an effect size of getting on for 1 standard deviation. So those are our hypotheses. This is the design that we made to test the hypotheses. This is a large randomized trial. In fact, it's by a good distance the largest that's yet been undertaken. You'll see with a sample size of over 150 children entered into it over 3 sites. Preschool ages, as you'll see, and they all had core autism disorder. This is an important fact because a lot of the previous intervention literature has not made clear where on the autism spectrum their children in the trials have been, and therefore it's been often difficult to evaluate the changes reported. We wanted to test a model deliverable within the UK NHS. In other words, it had to be practical. And importantly, we pre-specified the primary outcomes and analysis plan. This is another important methodological feature, which is in distinction from the kind of study or trial which undertakes a number of assessments and then at the end of the trial looks to see what patterns of improvement there are. To pre-specify the changes that we expect to see is a more rigorous test, but it's less subject to false positive error rates in the analysis. We did a lot of blinding of outcomes. And another feature of the study is that we designed it so that we could test mediating mechanisms in a way that I'll describe to you. So you'll see in the diagram on the right the pattern of our study with intake and then assessment at 7 months and then endpoint at 13 months. And you'll see it's a two-arm study. We were testing the intervention of interest against treatment as usual. And I'll come back to the issue around treatment as usual at the end. Well, the intervention is, as I said, a parent-mediated, video-aided intervention. The parents review videotapes of their play with their child along with the therapist and are encouraged to start to become sensitized to child's communications, which we know in autism are often of low amplitude, unclear, and difficult to read. And essentially the process of the treatment, at least in its early stages, is to help the parents start to read the child's signals better. And then as the treatment proceeds, it's got a developmentally staged aspect to it. And so as there's an achievement of parental synchrony, adaptive communication strategies are introduced and communication enhancement. So the intervention is staged to follow a developmental progression. The intensive part of the treatment was over the first 6 months, as you'll see, with clinic visits and intervening homework. And the next 6 months were generalization and booster work. Altogether, there were 18 possible sessions to have in the intervention, and our parents really completed these very well, as you'll see. They almost all completed almost all the sessions. So it's a well-accepted treatment. Now, in terms of choosing outcomes, another crucial area, which Sally also mentioned, which I'll come back to in our discussion, but we did choose the ADOS-G. We slightly modified the ADOS algorithm total score, which is what we used as the outcome, pre-specified outcome. And we slightly modified it to enhance its sensitivity to change. And then we looked at, we had secondary outcomes, which were the parent-child interaction measure, which was our observation of the parent and child interacting in ways that we hypothesized would be changed by the treatment. In other words, we hypothesized that parents' synchronous responses would be improved and child communication initiations would also be improved. We had an independent measure of language and social adaptation. And then we had some parent ratings of both language and social communicative development. So these were our main outcome measures that we designed in. So here are the results of or some of the first results from this study. Here's the flow chart. You'll see that, as I said, we randomized 152. Almost all our patients, our families in the intervention arm, PACT intervention arm, completed the therapy. You'll see we had very few losses to follow up. And this is an important aspect. There was very low attrition in this study. And we were able to analyze at the end with very little missing data. The internal validity of the trial was very high, so the groups were very balanced. We had consistent staff with blind ratings, and treatment as usual was very balanced across the groups. So our PACT intervention was added on to treatment as usual, and we monitored what treatment that both arms of the study had, and they had both quite a high level of ordinary treatment. And again, this is a subject for discussion. Our external validity, this was a very representative group of families we were studying, and you'll see there the statistical analysis that we undertook. So the first results relate to this first hypothesis. In other words, would the intervention with the parents improve their functioning and improve the child's initiations? And here you'll see on these, these bar charts, we have the red bars are the treatment as usual arm and the green are the PACT arm. In each, this is at baseline. This is at midpoint at 7 months, and this is at endpoint at 13 months. and this is parental synchrony, and you'll see that from equal synchrony at baseline, we had a very substantive enhancement in parental synchrony at halfway, and that had pretty much maintained by the endpoint in comparison to the TAU group. And you'll see that the odds ratios and the effect size here is very substantial. So this was a really substantial effect size on parental functioning. Then if you look on the right-hand chart, it's the same layout, green for the PACT, red for the TAU, baseline, midpoint, endpoint. And you'll see we got a similar pattern here, slightly less strength of effect, but we still got a high treatment effect on child initiations within the dyadic communication. In other words, the intervention was having a specific effect on the amount of communication the child was doing with its parent. And as you'll see here, these effect sizes are moderate to high with high odds ratios. Okay, so here is the language scores. These are interviewer rated, so they're blind to treatment allocation. And you'll see here that when we looked at receptive and expressive language on the PLS, we got no treatment effect. This is a baseline and endpoint for receptive and expressive. So we got no treatment effect in the child's language. And here is our primary outcome measure, which was the ADOS, G, Social Communication Algorithm Total. And you'll see here an interesting pattern, which is that as other speakers have commented this afternoon, we got a reduction in ADOS score in both groups, but not a significant difference. So the ADOS in the PAC group went down by about 4, and in the TAU by about 3, but this wasn't a significant difference. Turning to parent report. So these are the parents talking about how their children are doing after the treatment. Here we saw big treatment effects. So the parents felt that their children were doing much better in the PAC treatment arm than in the treatment as usual. But of course the parents were not blind to treatment. They knew that they were getting this additional treatment.